Good afternoon, everybody. Welcome to another edition of the AFR EMS case studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire. And today we're joined by our Medical Director, Dr. Kim Pruitt.
Hi, Chief.
Thanks, Doc. And we're joined by Lieutenant Jeff Bussey.
Hey, Chief.
From the 69th Cadet class.
That's the best one.
Best class so far. I don't care what
It's going
those
to piss off a lot of people, but that's all right.
Well, thank you. We have an interesting case with a lot of moving parts that we want to kind of touch on all of it. But this was a call that you took with Rescue 15 and Engine 15. I'll set the stage that it was about mid-May, so although it was warm, definitely not the same warmth that we're seeing now towards the end of July. And this is a hyperthermia case. However, it was dispatched as a 31 Delta for an 82-year-old male who had collapsed in his yard. You don't have the hyperthermia information yet. You just know that it's somebody down in their yard. So talk through with us what you're thinking about when you're on your way to this call.
So just go to this, and we don't really know what it is. It's an elderly person, so thinking maybe it's cardiac, maybe it's diabetic. I have no idea what it is, to be honest with you. So when we rolled up, we found this individual. He was laying outside, like you had said. It was a pretty warm day. I think it was upper 80s or 90s, something like that. But he was laying in the direct sunlight and full pants, two heavy flannel shirts on, and he's just not responding to us at all. He's very diaphoretic. He's altered, not answering any kind of questions or anything like that. So we're kind of not exactly sure what's going on there. But
does he respond to you at all, or is it just?
He's not really responding at all. He's not making kind of any sounds or anything like that. The only info we have on this individual was an elderly neighbor. Said that she didn't know how long he'd been out there, but it appeared maybe he was trying to take out the trash or the mail, and she had heard him making some kind of noise. She told us he was on hospice. She didn't know why. And that's all we had. But okay. He was, like I said, very diaphoretic and not responding to us at all.
Okay. Your first actions, I'm assuming, was did you treat there in place? Did you move him to the ambulance or move to a different area, or did you just start there?
5-5 wasn't on scene just yet. So we were trying to treat him there and see what we could get some vital signs on him, get a sugar, see if maybe that's why he went down.
We'll talk through some of your vitals that you had documented. So it looks like 64 for an initial heart rate. His blood pressure was 80/40, respiratory rate of 32, had a blood sugar of 324, and then you registered a temperature, I'm assuming tympanic, of 106.
Correct.
Okay.
So he was, like I said, just his condition and how he appeared with all of those clothes on, heavy clothes. We started trying to get those clothes off as quickly as possible, active cooling with the cold packs as best we could. And then once we saw that pressure, we knew we had to get some fluid bolus on board as well. So,
Doc, talk to us a little bit about heat stroke and what we're looking at. Obviously, that's hyperthermia, anything over 104. What are we going to start seeing in those patients once they reach that temp?
So the definition of heat stroke is a high body temp plus altered mental status, and this guy definitely met that criteria. The cerebellum is actually particularly vulnerable to overheated temperatures, and so it's not uncommon right before they hit that altered mental status kind of level to be a little off balance or a little confused, or sometimes even have a seizure, which is also not very uncommon with these things. It's a very important call and something very important to recognize this time of year because the mortality is actually very high.
He kind of almost seemed, you mentioned seizure, he kind of almost seemed a little postictal, but we weren't getting any response from him. Just to kind of touch back, the neighbor said he was on hospice, but we didn't know why. Mm-hmm. And we kind of went with, I don't know why he's on hospice, but this seems like it's an acute problem. So regardless of why he's on there, we're gonna take him anyway, and we'll figure out hospice later.
Yeah, that's a great point. I appreciate you bringing that up because we encounter many hospice patients in the field, and as we know, there's typically some chronic condition as to why they're placed on hospice, but that's not always the case. Sometimes if it's just in terms of the level of care that they need at home, sometimes they'll be placed on hospice, and I think there's a misconception out there that for any reason that they go to the emergency room that they're going to lose their hospice care, and that's not always the case. So if it's something acute, something emergent, they have a broken arm, broken leg, something happens, we can still help them, comfort care, treatment, and even transport without affecting their hospice coverage. But it's always important to talk with the hospice nurses or at least the hospice company if you can. But outside of that, it's not against the rules to be able to transport them even though they're on hospice. So I appreciate you bringing that up and us talking through that a little bit too. So 106, you pretty much now know what you're dealing with. You talked about how you started the the passive cooling by getting some of that clothing off. In terms of treatment, was there anything else you were thinking or doing at that point?
So kind of around this time, 5.5 got there. We got them loaded up, kind of let them know that we need all of their cold packs too. We used all the ones we had. So we put them on the 12 lead, and we were going to, this is going to be code 3 back to the hospital. Put him on the 12 lead, and his QRS was very wide. So myself and the medic on 5.5, we started thinking, we've got one fluid bolus on board. We're looking at maybe getting another line. And then we start discussing, maybe an antiarrhythmic. We don't want that wide QRS to just get wider and turn into fib. So as we're doing kind of some of those interventions and trying to make those decisions, en route to the hospital, this individual coded on us. So.
And there are so many things we can talk about within the 12 lead itself, Doc, but can you talk through why Lieutenant Bussey and his team would have been seeing that widened QRS?
Yeah, there's a couple of reasons. One, this patient was in extremis, right? Didn't have a single normal vital sign as far as I can tell. And in a condition with a super high mortality, we don't know how long he was down. We don't know any previous medical history. And my suspicion would be with a blood pressure like that, he probably was developing a little bit of acidemia. And anytime you get a little acidotic, your potassium can go up. And if he had some underlying kidney disease with that as well, I'd be concerned, one, about just arrhythmia in general, because this still could have been a cardiac event, right? And he's got a couple bundle branch block on his 12 lead. So we know he's got some underlying cardiac disease. And then the suspicion for hyper K with a very, very wide QRS, I would suspect that could have played into it as well, but it's really hard to tell. It's a complicated 12 lead.
Yeah.
It was one of those, once we got the 12 lead and we're trying to decide what route to take next, there was not a lot of time from trying to decipher our 12 lead to now he's got no pulse, and kind of switch, total change of gears. And luckily we were able to relay up to the driver of 5.5 to just go ahead and radio it in that things have changed and we're now working a code in the back of the truck.
Mm-hmm. We progressed into that cardiac arrest, and we had the information potentially that this patient was on hospice before. Was anything ever furnished to you all in regards to officially the hospice care or DNRs, most forms, anything?
No, because I believe this individual lived by himself. So the only thing that we were able to get was information from a neighbor, and she, did not know all of his medical history. So I don't know if family members were contacted later or how that went about, but we were just going based on what the neighbor had said.
Okay.
So.
And then your treatments in the back, once you had progressed, obviously you guys saw the wide rhythm, you were starting to prep for treatment of that, you had your IVs going, trying to actively cool the patient, still coded. What was your care after that point once the patient had coded, aside from the call to let them know that's what you were working?
We just diverted to strictly BLS with just the two of us back there. My partner started doing compressions, and I started bagging and trying to get an LMA as best we could. And by that point, we were kind of pulling up to the hospital and just doing compressions on the way in. So. Yeah.
It was a fantastic job in a difficult situation with a very difficult patient and a lot of moving parts to it. I think there was a really important case because we're in the thick right now of probably 2 weeks of some of the hottest weather that we've had. And Doc, you had made mention of just through your QA, you've already identified multiple patients that we've come across that were probably hyperthermic, which led to their arrest. Do you want to talk through some of the things we should be looking for other than what we've talked about here?
Actually, I really appreciate your approach to this call. You have an unresponsive patient. You recognize vital signs are vital, including temperature. Not a lot of people think to get that. I recognize that his clothing was a little inappropriate for the environment, but checking that temp early, recognizing, change in direction from unresponsive patient with a pressure of 80 over 40, I'd be thinking cardiac, get the 12 lead, but you focused on exposure first, which was the right first move. And then cooling after that. You can't cool these patients fast enough. So I know sometimes with cold patients, we try to cool them gently and slowly over time, but with heat emergencies, you want to, if we had an ice bath, we'd throw them in the ice bath, right? You can reverse that quickly. And elderly patients are especially vulnerable for this. So you caught the problem, you addressed the problem, then you started to attack that blood pressure. You did everything in the right sequence. And unfortunately, this one coded, which can happen. Another thing that's not uncommon is seizures. So I'd be prepared for that if you see it again. And you can still treat that with Versed. but we're seeing it like I'm aware of at least 3 cases just this month with this heat wave that we're having. So it's a good one to be talking about now.
And it may be a silly question, but if we have a patient who isn't completely altered like Jeff and his team had, we all have, those of us have had kiddos, we know when they get fevers, we treat them with antipyretic, right? Is that even an option in these hyperthermic cases that's secondary to environmental exposures?
If they're still in a state where they can take PO, I think it's worth a try. It's probably a different mechanism, but I actually took care of one of these patients in the hospital recently, and sepsis was still high on my differential for her, and I did give some Tylenol to try to help because I wasn't exactly sure. I suspected environmental, but sometimes the pictures are mixed, and I don't think it would hurt.
Okay.
So another nice little cooling trick you can do, I know sometimes our ice packs aren't as aggressively cold as we'd like them to be, putting them in the arms and the groin and the neck. You can wet a sheet and just get it wet, and it'll start to cool with the AC in the back if you want to cover them with something wet.
That's great. Good info. Very interesting case. Anything else, Jeff, that you want to share with anybody who would respond to a call like this? Anything you have done differently, done the same, things you took away from this call?
I don't necessarily think so. I feel like, we did the best with what we could. Tried just to cool them as fast as possible, and then just try to go down the list and see what we can fix when we can. Mm-hmm. And then, when everything crashed on us, we just revert back to the basics and just go from there.
Yep. Fantastic. Great job. I appreciate your work, and I appreciate you coming to talk to us about it. Thank you, Doc, as always. That's it for today's case study. If anybody has any additional case studies they'd like to submit, please use the SharePoint tab. Otherwise, you can reach out to your 7-8. And until then, we'll see you next time.